We're now going to be transitioning to looking at heart failure, which is the culmination of all of the pathologies we've discussed in Module 4 coming together. Ultimately, cardiac patients are going to end up with a form of heart failure, and we'll now look at the pathophysiology that involves.
Heart failure is a devastating disease, and according to the CDC, there are about 5.7 million adults in the U.S. with heart failure, and it causes 1 in 9 deaths as of 2009. It's estimated to cost the U.S. $30.7 billion each year. So, by definition, heart failure is a secondary condition caused by the heart pumping ineffectively and thereby not maintaining adequate perfusion of the tissues. So diseases that damage the heart and blood vessels place people at a greater risk for heart disease. For example, CAD, hypertension, diabetes, obesity, tobacco use, cardiomyopathies, congenital heart defects, lung diseases like a pulmonary embolism, sleep apnea, and arrhythmias can all lead to heart failure. So if we look at the etiology, so we've named some, but we can actually divide and organize these. So heart failure can be caused by ineffective pumping. Ineffective pumping is caused by myocardial infarctions, structural defects to the heart, or infection and inflammation. Heart failure can also be caused by an increased workload on the heart. Hypertension does that by raising afterload. Hypervolemia, which can also increase afterload by increasing blood volume and blood pressure, and anemia, where our cardiovascular system is going to work overtime because we don't have enough oxygen. There are many causes of heart failure, and so we can look at a couple of these. So we've listed already those at the heart. So arrhythmias, congenital heart problems, myocardial infarctions, valvular disease, myopathies, viral infections. But there are other ones as well. So I just want to highlight some of these and how they work. So for instance, coronary artery disease, or CAD, or atherosclerosis, that can decrease the oxygen to the myocardiocytes, increase myocardial infarctions, which decrease contractility, decrease cardiac output, and lead to heart failure. Hypertension is one that we have mentioned. High blood pressure, right? So an increase in afterload can decrease your cardiac output, and that eventually increases workload and oxygen demand on the heart. The cardiomyopathies enlarge the heart muscle, and that can be from infection, alcoholism, steroid use, even collagen disorders. Cardiomyopathies, remember, make ineffective contractions that decrease our cardiac output. Valvular disease. The valves don't close, and that can overload the ventricles with blood. The muscle stretches and increases the oxygen and energy demand necessary to pump that volume of blood. Other causes include diabetes, which is ultimately a vascular disease, so it leads to atherosclerosis. Certain drugs can influence the heart, and also kidney issues. Kidneys will affect our blood volume and our blood pressure. When you think about pathogenesis of heart failure and the mechanism, it's really helpful to think about a clogged sink. So if you've ever experienced a clogged sink, you know that water from the faucet can keep coming, but the forward flow of water down the drain doesn't occur. So what happens to the water? Well, it starts to back up into the sink, and if this water keeps on coming, eventually the water is going to spill out of the sink and right onto the floor. The mechanism of heart failure is similar. Because the heart is not pumping appropriately, blood is going to back up wherever that blood is arriving from. And so where we see the backup of blood, that's going to give us our symptoms. Either side of the heart can be injured and fail to contract properly. Since each side pumps for a different circulation and the blood is arriving to the heart from different places, if that forward movement of blood is hindered, the blood's going to back up into either the pulmonary or the systemic circulations. While we name the type of heart failure based on which side of the heart has the issue, I want to make sure that you realize that the heart as a whole is probably damaged and ineffective. So let's start at the right side of the heart. In right heart failure, the heart is not pushing deoxygenated blood into the pulmonary circulation to be delivered to the lungs. Since this movement is inhibited, the blood is going to back up into the peripheral tissues, and we're going to see congestion in the peripheral tissues. Right-sided heart failure is caused by conditions that stop the blood from being able to move into the lungs. So things that can cause higher pulmonary blood pressure and make it difficult for the right ventricle to pump can lead to right-sided heart failure. Lung injury, infections, inflammation, pulmonary edema, like from left heart failure, can also be causes, as well as CAD and hypertension. The clinical manifestations are related to the congestion or swelling or edema of those peripheral tissues, since the blood's going to back up in the periphery because it can't move forward. Ascites is when there's blood, or I should say edema, in the abdominal area and swelling there from an excess of fluid, especially in the portal vein. There can be GI tract congestion, and that can lead to anorexia, GI tract problems, and even weight loss. Generally, the edema can be seen in the distal extremities, like the feet and legs. They start to swell, and then it makes its way up towards the abdomen. Left-sided heart failure can be caused by a decrease in cardiac output or pulmonary congestion. It typically develops prior to right-sided heart failure. So in left-sided heart failure, the blood will not be moving forward into the systemic circulation, and instead it's going to back up into the pulmonary circuit. So the signs and symptoms that we have are those that affect the lungs and also the systemic tissues, as they are not receiving enough perfusion and oxygen. So the decrease in cardiac output can cause exercise or activity intolerance because patients are quickly tired and out of breath. The tissues are not going to have adequate perfusion to meet the metabolic needs here. The pulmonary congestion also gives rise to some signs and symptoms. So there is impaired gas exchange, and that can cause cyanosis, which is that bluish color to the mucous membranes, and signs of hypoxia in the tissues. There's also pulmonary edema, and with that we will have patients that will have a cough, orthopnea, which is when we'll have shortness of breath when they're lying down, and paroxysmal nocturnal dyspnea, which is like a severe cough and shortness of breath. Generally happens at night when a patient is lying down and sleeping, and it awakens the patient, and it can be very anxiety causing. There are other ways heart failure can be classified as well, and these help to give a clear picture of the pathology of the disease. So there can be systolic or diastolic heart disease. In systolic, the left ventricle fails to pump efficiently, and there's a decrease in cardiac output. This is referred to as systolic failure. Diastolic failure is when the left ventricle is rigid and can't relax enough to properly fill. And here, the end diastolic volume will be decreased, as well as our stroke volume and cardiac output. We can also have acute or chronic heart failure. With acute, there's a very rapid onset of our heart failure, and the compensatory mechanisms are not yet in place. With chronic heart failure, it is long-term, and the body does have compensatory mechanisms trying to correct the altered physiology. So we've been highlighting the clinical manifestations of heart failure as we've discussed the pathophysiology. It's also helpful to lay it out as well and put it into one slide with our clinical manifestations. So we're going to break it down into different categories. So we'll first look at respiratory function and how it can be altered in heart failure and the signs and symptoms we see. So if you remember, shortness of breath is dyspnea, and we see that with our patients. There's also exertional dyspnea, and that's a shortness of breath linked to activity. Orthopnea is a shortness of breath when the patient is lying down on his back or in a supine position. Paroxysmal nocturnal dyspnea is when the patient is awakened because of a shortness of breath or cough, and it's generally experienced at night. And it can be a scary experience, and it often brings on anxiety because patients feel like they can't breathe. Patients can also have a dry, chronic cough that can worsen when they lie down. And cardiac asthma is a bronchospasm from congested bronchioles, and that can lead to wheezing or difficulty breathing. Because of the decreased perfusion and oxygen levels, patients also experience a lot of fatigue and weakness. Mental confusion occurs because there's less oxygen going to the brain. As we've discussed, the congestion name in heart failure is because there is fluid retention. And so we see fluid retention and edema occurring where the blood backs up in either the systemic or the pulmonary circulation. So an early stage of heart failure can be nocturia, which is an increase in night urination. And that's because there's an uptick in the glomerular filtration rate as a compensatory mechanism to the increase in cardiac output as the heart is trying to make sure to maintain its cardiac output. In late stage heart failure, oliguria occurs, which is a decrease in the urine output because of a decrease in cardiac output and renal failure. Edema is when the fluid collects in the tissues as the vascular systems get overwhelmed. Fluid that moves into the thorax is called hydrothorax, and if it moves into the abdominal cavity, it's called ascites. Pleural effusion is when the fluid moves into the pleural cavity, which is going to affect lung functioning as well. In the end stage of heart failure, patients generally suffer from malnutrition and tissue wasting, which causes them to drastically lose weight. So this is called cardiac cachexia. And it's thought that depression from an end-stage illness, the fullness feeling maybe from the edema, and also toxins might give way to that pathology. Cyanosis is that bluish tint to the skin because of a decrease in oxygen. And lastly, arrhythmias can occur in heart failure. Atrial fibrillation is the most common. Patients with heart failure are also at a greater risk for cardiac arrest, which is the abrupt loss of heart function, and that can quickly cause death. As the cardiac output decreases, there's a number of compensatory mechanisms the body uses to try to raise and maintain cardiac output. With chronic heart failure, the myocardial hypertrophy and remodeling in the heart muscle occurs. The idea here is that the heart is trying to increase the muscle and its ability to contract to increase stroke volume. There are also sympathetic reflexes that can increase contractility and heart rate in an attempt to try to increase our cardiac output. So here you could see these reflexes increasing contractility and our heart rate. Also, the sympathetic nervous system is going to cause vasoconstriction to try to raise blood pressure and cardiac output. The RAS system is also turned on, and our kidneys secrete renin, which eventually gets converted into angiotensin II, and then we'll have the hormones ADH and aldosterone working to reabsorb sodium and retain water. And so what that does is it gives a greater blood volume, so we have more venous return and hopefully a greater preload, and then that is going to hopefully help the heart to contract stronger or more forcefully to increase the cardiac output. So heart failure is diagnosed by the presence of the clinical manifestations. Chest x-rays can be used to assess pulmonary congestion, and then we can use echocardiography to assess the structure and function of the heart, and ECG to determine whether or not there's any conduction abnormalities. Treatment, we want to start by trying to see if there are any underlying pathologies and treating those. So for instance, if there are valve issues, replace the valves. We can use revascularization or treat anemia, etc. Lifestyle changes help, especially with those compensatory mechanisms. So we put patients on a low sodium diet, ask them to stop alcohol or tobacco use and lose weight. Oxygen therapy might be necessary for some patients. especially if there is pulmonary involvement. And then we can use pharmaceuticals to manage the compensatory mechanisms. The pharmaceuticals work to decrease blood volume. So that way there is a decrease in blood pressure and then decreasing our afterload to make it easier for the heart to work. We can also use pharmaceuticals to improve contractility of the heart muscle. So that way it can try to maintain cardiac output. And we can also use other drugs to disrupt the sympathetic nervous system stimulation as well. So that way it makes it easier for our heart muscle to continue to work. The next condition we're going to examine is shock. When the circulatory system fails to perfuse vital organs with the appropriate amount of blood, the condition of shock can occur. For there to be proper blood flow in the body, the heart has to pump out an adequate cardiac output, and blood vessels must have appropriate resistance to maintain blood flow. If either of those things are deficient, shock can occur. There's different classifications of shock based on the deficiency that's decreasing our blood flow. Ultimately, the decreased blood flow causes tissue hypoxia, damaging cellular metabolism, and ultimately leading to acidosis. The continued dysregulation eventually leads to fluid imbalances in cells. And what we see is that they'll have an intake of water, they swell, and then they can die. Untreated shock generally leads to multiple organ failure, including the heart, brain, kidneys, and lungs. So this flow chart shows us the different classifications of shock and the deficiency that leads to it. So we can have shock based on deficient cardiac output. And the types of shock that we have that are triggered by a decrease in cardiac output, we consider cardiogenic and hypovolemic. We can also have shock triggered by deficient peripheral resistance or systemic vasodilation. And here we can have septic shock, neurogenic shock, and anaphylactic shock. So we're going to break these down so we can see what causes them and then also interventions that we have to help. So first, we're going to look at the circulatory types of shock brought on by a deficient cardiac output. So remember, if the cardiac output decreases, blood pressure and perfusion of the vital organs are also going to decrease. The treatments for these types of shock include improving the efficiency of the heart by improving cardiac output while decreasing the workload on the heart and replacing fluids and blood. So the first type of shock is cardiogenic shock, and it's brought on by an ineffective cardiac pumping or a decrease in contractility. So this can be caused by myocardial infarction. If it's not addressed quickly, it leads to systemic hypotension, pulmonary edema, and as the blood will back up in the lungs. The mortality rate is 70% for patients who are not treated. The clinical manifestations are also dependent upon the triggering event. So with cardiogenic shock, that would be those associated with a myocardial infarction or heart attack, like chest pain, difficulty breathing, perhaps nausea, vomiting. It's treated then by a bypass, drugs that can increase our cardiac output, blood pressure, and decrease the workload on the heart. So drugs that are given to myocardial infarction patients. Hypovolemic shock occurs when there is a decrease in the blood volume. A decreased blood volume would inhibit venous return of blood, thereby decreasing the end diastolic volume, the stroke volume, and the cardiac output. Blood volume decreases with hemorrhage, burns, severe diarrhea, or polyuria. Generally, hypovolemic shock occurs if the blood volume drops between 15 to 20%, and the clinical manifestations would be related to the amount of blood loss. So here, our interventions include stopping the bleeding and fluid and blood replacement and oxygen. So here we can sort of see the compensatory mechanisms for hypovolemic shock. So there's acute bleeding or something that's going to lead to a decrease in blood volume. So the body is going to try to work to stabilize and bring that blood volume back into homeostasis. So the mechanisms that the cardiovascular system can use, it can increase heart rate and cardiac contractility to try to maintain cardiac output. And we can see vasoconstriction to try to increase the blood pressure. Now, think about it. An increase in blood pressure and cardiac output is going to push blood to, for instance, like this wound, and we can see more bleeding. Other mechanisms to maintain the blood volume. So we will have the stimulation of antidiuretic hormone. The kidneys are going to try to reabsorb sodium, have water retention, decrease the urine output. We'll also have aldosterone to reabsorb the sodium. And then there will be constriction of veins to mobilize the blood stored in the liver as well and put that into the circulation. The other types of shock occur because of deficient peripheral resistance or systemic vasodilation. With a decrease in resistance and vasodilation, there's not going to be enough blood pressure to push the blood back to the heart. So the treatments for these particular types of shock are aimed at addressing the cause of the shock and then increasing vasoconstriction and contractility. So the first type of shock here is septic shock, which is generally caused by a serious infection. Infectious bacteria can release endotoxins that trigger a huge inflammatory response, and this can damage the blood vessels' endothelium, making it leaky and permeable, so fluid escapes the vasculature, and as well, it can trigger vasodilation. So septic shock has a mortality rate of about 30 to 50%. The clinical manifestations are related to the underlying infection, for instance, fever. So here we can see how this works. So microorganisms are suspected of causing an infection and releasing endotoxins, and that's going to disrupt or impair the endothelium. We're going to see a large systemic inflammatory response, and then we can have systemic issues, multiple organ systems involved, and severe sepsis. So that vasodilation can cause hypotension, hypoxemia, which is a decrease in our oxygen levels, oliguria, which is again a decrease in urine, metabolic acidosis, and thrombocytopenia. And that all leads to septic shock. We can give antibiotic drugs or drugs that cause vasoconstriction to try to counter the vasodilation. The next type is neurogenic shock, and that occurs from injury in the brain or spinal cord that can inhibit their function. We also see it occurring because of drugs, anesthesia, hypoglycemia, or hypoxia. So the decreased central nervous system function will inhibit the sympathetic nervous systems controlling vascular tone, and that's what leads to the vasodilation. This is the rarest type of shock, and it's generally treatable. Anaphylactic shock is one that we have talked about in our immune module. Anaphylactic shock is triggered by an immunoglobulin E hypersensitivity reaction. The inflammatory response triggers massive vasodilation. It decreases resistance and blood pressure. So the clinical manifestations are related to the anaphylaxis. So skin flushing, hives, airway obstruction. We can give corticosteroids and anti-inflammatories to try to decrease the inflammatory response.
So that wraps up Module 4, and we've covered a lot of ground. We've looked at the components of blood and pathologies of the hemopoietic system. We've considered the blood vessels and the physiology of blood flow and how disease pathologies can disrupt it. And we've also now considered cardiac pathologies with the heart and how ultimately those different pathologies can lead to heart failure. As well, we've wrapped up and looked at circulatory shock, which can occur in patients that have these pathologies.